Our final speaker for the session is Dr. Dalal Haqqan. She graduated from the Kuwait University Faculty of Medicine in Mubarak Al-Kabir Hospital. She completed her internal medicine residency in the University of Miami with ABIM certification and completed her gastroenterology fellowship and transplant hepatology in Georgetown University in Washington, D.C. And her research interest includes drug and herbal supplement-induced liver injury and quality improvement. So she's going to talk about drug-induced liver injury daily in clinical practice. Dr. Dalal.
Okay, good morning, everyone. I'd like to thank the organizers for inviting me to be here today. It's such a pleasure. So my talk is going to be actually a case presentation on drug-induced liver injury. I don't have any financial disclosures. So let's meet our patient. So it's a 55-year-old Kuwaiti female who presented to the hospital with a 3-week history of progressively worsening jaundice and vague abdominal pain associated with nausea without vomiting. This is her first presentation. She's never had any similar complaints in the past. She says she's been previously healthy, never needed hospitalization, and she does a yearly wellness visit with her primary care provider. She has no known medical problems, never had any surgeries. Her family history, she just has a brother with hypertension. Nobody in the family has any known liver disease or autoimmune diseases. She doesn't have any allergies, and she's not denied taking any medications on a regular basis. So on admission, her vital signs were all within normal limits. Her BMI was 23, and then her exam was unremarkable except for prominent jaundice. As you can see in her labs, her CBC was essentially normal. Her coags were elevated with an INR of 2.24. Her electrolytes, there was just minor hypokalemia. But as you can see, the liver enzymes were pretty high on admission. Her AST was in the 1500s, ALT in the 1900s. The ALP was 219, GGT 144, T-bill of 440, and the direct bilirubin is 295. And then the initial ultrasound abdomen with Doppler that was ordered on admission showed features of acute hepatitis, steatosis, and normal Doppler waveform. During the admission, viral hepatitis markers were ordered, and they were negative. Her autoimmune markers were all negative except for positive ANA. With a positive titer of 1.640 and the ferritin of 2500. And the rest of the serologies were essentially negative. And then her MELD on admission was calculated at 33. So at this point, what is our main differential diagnosis for this patient? Based on the very short history that we have, Dr. Mu'taz, Dr. Kennedy, how would you kind of approach this patient?
Assalamu alaikum, sabah al-khair, and thank you so much for inviting me in this very prestigious meeting. Actually, I feel like home as usual. Dr. Dalal, this is an interesting case and interesting scenario, and we see it a lot, unfortunately. So she had an herbal medicine brought from Iran, and now she's having high level enzymes, and ANA is positive, 1/640, and she is a middle-aged female. So is it an de novo AIH or is it drug-mediated AIH? So I will put these two differential as first options.
Yes, basically, so the proper history, when we were able to go and actually see the patient, when we asked her specifically if she took herbal supplements, she said yes, and she actually had the supplement with her. So the first point to make is if you don't ask the patient specifically about herbal supplements, they're not going to volunteer that information as part of their drug history because most people don't consider herbal supplements as drugs. And unless you specifically mention it, you're not really going to get that in the beginning of the history. And whenever we hear about herbal supplements, that comes into our differential diagnosis as either drug-induced or autoimmune hepatitis, as Dr. Mu'taz said. So
yes, I strongly agree with you, Dr. Dalal, because patients usually they don't consider those as medicine. You know, it's herbs, so it's nice back, so it's healthy. So you should ask specifically. I totally agree. Yes.
Yeah, and the general kind of perception of in the population is that all herbal and dietary supplements are completely harmless, which is wrong. So they don't even consider it as a potential trigger for their presentation. So unless you ask, they're not really going to tell you. So what do we know about the epidemiology of drug-induced liver injury? So our estimates are between 14 and 19 cases per 100,000 per year. In 2023, there were over 2,500 articles published, which is more than triple the amount 20 years ago. And then we know that DILI accounts for over 50% of cases of acute liver failure in the US. And then when you have DILI presenting with jaundice, like our patient, there's a 10% mortality associated with that. In terms of etiology, in most Western countries, according to the American DILI Network, antibiotics are usually the most implicated at 45%. Second comes the non-steroidals, and then third is the herbal and dietary supplements at 16%. If you compare that to Asian countries, the herbal and dietary supplements actually are number one, representing about 70% of all cases of DILI, and that includes traditional Chinese medicines, green tea extracts, turmeric, ashwagandha, etc. And then you have anti-TB medications and antibiotics coming in second. But what about us in the Middle East and GCC countries? Do we have any data? Do we know what's most common here? Any thoughts, Dr. Mu'taz, Dr. Kennedy? What do you think our epidemiology is going to be like here in terms of etiology of DILI?
Yeah, no, I mean, it's fascinating. I always get extremely concerned when I hear people talking about cleansers like this renal kidney cleanse treatment. Interestingly, I think turmeric, we've seen excessive use of turmeric. So certainly our experience is that people are told that turmeric is very good. It's antioxidant in some of its mechanisms. But we've seen cases of turmeric toxicity exactly as you pointed out. So I think that's really fascinating. The other point that I would highlight is the issue around age. When you get jaundice with drug-induced liver injury in an older patient, it really sets off alarm bells for me. So that's one of the things that I'm always very worried about. Yeah.
Mm-hmm. And Dr. Mu'taz, your experience in the Middle East, where do you think we lie between Western countries and Asian countries? Are we more towards the etiology being herbal versus medications such as antibiotics, or are we kind of in the middle?
Yes, now when it was the era of social media and mostly females are very concerned about their weight. So they tend to buy a lot of herbs online for losing weight. So for me, in my practice in Egypt, yes, I see it a lot. For those patients who are trying to lose weight and they take herbs over the counter or from online, so they develop this kind of insult. The second one, it's not really insult like about the statins. You know, Dr. Ma'an was talking about, colleagues in medicine and cardiology, they get terrified when they see just slight elevation of ALT when they give a statin. Although statin is very important for those patients, they tend to stop it for a long time. So these are the most common two forms I see in Egypt.
Mm-hmm. So I think in general, probably consensus is we probably are somewhere in the middle between the two regions.
Yes.
We do use a lot of herbal supplements. We have a lot of herbal teas. Even traditionally, I'm sure you've been in Kuwait the past couple of days, someone's tried to serve you some herbal tea or something while you've been here. Yes. So it's very popular here as well. So what about herbal-induced liver injury versus drug-induced? So the latest data from the Drug-Induced Liver Injury Network that reports about 20% of liver injury is due to herbal and dietary supplements within the drug-induced liver injuries. And then many of the herbal and dietary supplements are actually mislabeled, so they don't include all of the ingredients that are put into those supplements. A lot of them are contaminated. And then we don't really have any regulations on those herbal and dietary supplements, at least in North America yet. So it's very difficult to diagnose it because there's variability between each batch. There's a latency of exposure. There's a change in the supplement over time. And likely some ingredients that are included are not listed on the packaging. Also, herbal-induced liver injury has a higher rate of complications with a higher mortality rate compared to just conventional drug-induced liver injury at 12.6% versus 8%. And then some factors that are associated with increased mortality in herbal-induced liver injury include elevated liver enzymes at baseline, use of crude or unprocessed herbal supplements, and being a hepatitis B carrier. So how do these patients typically present? So it's a spectrum. So they can either have asymptomatic liver enzyme elevations detected incidentally, or they can present just like our patient with vague symptoms, fatigue, jaundice, pruritus, or nausea, or they can come at the other end of the extreme and acute liver failure. So the diagnosis of DILI, as we were talking, is pretty challenging. You really have to have a good history, because if the patient doesn't tell you they took something, it's really going to be hard to actually diagnose it as a drug-induced liver injury. It's uncommon, there's no standardized diagnostic criteria, and we don't really have any well-established biomarkers, although there are some research papers being published in this biomarker field over the past few years for specific drugs. The most important thing that I want to highlight is that we really have to rule out other etiologies. This is a diagnosis of exclusion, and I just want to highlight ruling out hepatitis C and E. We do have some data that, in particular, hepatitis C and hepatitis E can masquerade as drug-induced liver injury. There's an interesting study that was done in Egypt on hepatitis E, and they basically did a retrospective study on the plasma from 80 patients who they thought were a drug-induced liver injury, and then going back, they found that a lot of these patients had a positive hepatitis E IgM, and basically was about 15% of these patients. So please make sure you order the appropriate viral hepatitis serologies, and then obviously the one that we confuse the drug-induced liver injury with the most is the autoimmune hepatitis. Those are the two that we kind of struggle to differentiate between the two at the initial presentation. So these are just proposed or recommended criteria to think about drug-induced liver injury by the International Serious Adverse Events Consortium. If the ALT is 5 times the upper limit of normal, ALP more than 2 times the upper limit of normal, and ALT more than 3 times. This is not like a validated diagnostic criteria, but it helps guide your diagnosis. So what about causality assessment? Dr. Kennedy, are there any particular tools that you like to use to determine the causality in drug-induced liver injury? Do you refer to any specific causality assessment tools?
I mean, we certainly consider them, but I think it goes back to what you talked about at the very outset, about a good clinical history and actually the patient's understanding better that some of these over-the-counter or herbal remedies are potentially toxic. Interestingly, not that long ago, I had a patient who presented a very similar way to this, but they'd been using some agent to kill a fungal growth in basically a bedroom or something. So they were being exposed to a chemical in the same way as if you ingested it, because it was an aerated chemical. So I do think you have to keep a very open mind about this. I think the most important element of this to me is exactly as you said, is that very detailed history where sometimes you need to go over it again and again to understand where the potential toxin is.
Mm-hmm. Agreed. So some tools that are available to us, the one that I like to use the most almost in a daily practice is the LiverTox, which is the NIH search engine. Again, this is just to help guide you if you have questions regarding specific supplements or drugs that the patient is on. And we use the example of amoxicillin and clavulanate, which is a very common one of the more common antibiotics. As you can see, it'll give you a little bit of information on the hepatotoxicity, what to expect, the trend of the liver enzymes, the mechanism of the injury, and then the likelihood score that this drug caused your injury. And you can input all of the components or medications that the patient took to kind of help guide you in terms of likelihood. But then a better tool that's been used for over 35 years is the RUCAM score, which is the Russell-Uclaf causality assessment method. This was developed in the 1980s, but it's been revised a few times since then. And it basically is a structured, standardized, validated, hepatotoxicity-specific diagnostic approach, and you score specific drugs. But the problem with this is you actually have to score each drug again individually. And in the more recent years, this one was mostly used not really in clinical practice all the time, but for case reports and publications, They usually include the RUCAM score for the drug. In the past couple of years, they actually developed an electronic version of this called the DILI-RECAM score. So this is the electronic version of the RUCAM score. And actually, they made it a little bit easier interface for people to use. So it's online. You can enter all the data that you have regarding the patient, the liver enzymes, the drug itself. And it might be a little bit easier for people to use instead of the RUCAM score, which is more time-consuming. So I think this is more promising, and shifting towards an electronic, easier-to-use version might help us. And this will just help guide you in terms of likelihood of how likely that this substance or drug caused the liver injury in the patient. But again, it has yet to be validated discussing the electronic version of the RUCAM score. So what about prognosis? What do you think, Dr. Mataz, in our patient, with her clinical presentation and a MELD score of 33, are there any concerns you have regarding her prognosis?
Sorry, how old was she?
She's 55.
55, okay. I will get a bit scared because she was jaundiced. She had an bilirubin a little bit high, 2.3 milligram. So I will be anxious about her outcome. And here, one of the few instances in Dalal, I might think of steroids because of her highly positive ANA. So it needs discussion with the patient to explain how things are going and how dangerous this situation is. And we might do counseling about using steroids in this case.
Dr. Kennedy, any thoughts on starting a transplant evaluation on this patient? Would you consider that?
Yeah, absolutely. I think certainly in this case, as we talked about the age of the patient, the presentation, and even when we're considering steroids, in this case, I'd probably make a strong case to biopsy the patient, because if there's a lot of inflammatory activity based on the biopsy, I would probably go ahead and pulse them with steroids. That's probably what I do as a first-line step before kind of transplant consideration.
Okay. So just in terms of prognosis, only 10% of patients with DILI reach the threshold of ALF. Less than 20% develop chronic liver injury. And then if DILI presents with acute liver failure, the prognosis is about 40% that require liver transplant and 42% mortality. The majority of patients with herbal-induced liver injury do end up fully recovering from their liver injury, so about 94%. And we have some prognostic scores that have been developed to kind of assess the prognosis for these patients, including the MELD score. So a greater than or equal to 18 at the time of admission, such as in our patient, is found to be a poor predictor for poor outcomes. The serum albumin and the Charlson comorbidity index are other scoring systems that are used. So in this patient, again, her MELD score was 33 on admission, so we definitely did talk about getting transplant evaluation. The patient was a bit difficult, so she was very hesitant to go through with steroids or transplant evaluation, but we did start a soft evaluation where we ordered the testing that we need. If the patient obviously develops acute liver failure, these are patients that you definitely have to consider for a transplant, or if they have any evidence of decompensation. So back to our patient in our hospital course. So her AST and ALT actually ended up trending down very nicely. Her bilirubin peaked at around 600 and then began to trend down about 1 week into the hospitalization. Her electrolytes became deranged. So I don't know, I guess as a hepatologist, we get a little exciting when we see hypophosphatemia in this course because it indicates potentially liver recovery. She stayed for a few days in the hospital for repletion of her electrolytes and IV fluids, and then discharged with follow-up in our clinic in 1 week. Then during her follow-up, she developed lower extremity edema as well as abdominal distension and ascites. She was started on diuretics. And then these are her labs a week later. As you can see, the numbers trended out really nicely. So her bilirubin went down to 192 from 600, the alkaline phosphatase 171, and then her ALT/AST from 1500 and 1600 to 95 and 93. And she responded really well to the diuretics. And in terms of liver biopsy, we mentioned that Dr. Kennedy mentioned that earlier. We did discuss this with the patient, but she was very hesitant during the admission. She refused a liver biopsy at that time, but we did end up convincing her during the follow-up visit because of the decompensation. So she did end up getting a liver biopsy eventually. But you really don't need to do a liver biopsy to make the diagnosis initially. Sometimes the histopathology findings can be very variable, and a lot of times, depending on how good your pathologists are, they don't really give you a solid differentiation between autoimmune and a drug-induced, especially because some of the drug-induced liver injuries can present with autoimmune-like features. But if you have a patient in this situation where you have positive markers, you have that degree of elevation in liver enzymes, you are considering steroids, it's probably a better idea to get this up front. But in this case, the patient refused it initially, and then with the decompensations and the ascites, she finally agreed to get the liver biopsy. And again, it's mainly to help differentiate between autoimmune and drug-induced. So this is basically what I just mentioned. She had her liver biopsy, and it showed severe active cholestatic hepatitis with advanced architectural distortion. She had regenerative nodules, bridging fibrosis. There was no histologic features of autoimmune hepatitis. So the pathologist actually was pretty convinced that this went more with drug-induced liver injury based on the histopathology rather than autoimmune hepatitis. And then the regenerative nodules were thought to be more due to the acute liver injury and necrosis rather than being features of fibrosis and cirrhosis due to the extent of the injury. So she kept following up with me in clinic, and then 6 months later, she's feeling back to her normal self. She hasn't had any lower extremity edema or ascites. Her liver enzymes, the ASCLT completely normalized, the bilirubin normalized, and she's doing very well. So the take-home points for today's talk is that the incidence of DILI and HILI is on the rise worldwide. Many people shifting towards using natural and herbal remedies and supplements, especially after the COVID pandemic. There is a lack of regulations when it comes to herbal and dietary supplements in most countries. Meticulous history taking remains the cornerstone. Ask specific questions regarding drugs and herbal and dietary supplements because the patients generally will not volunteer that information. And it's important to exclude other etiologies first, as DILI remains a diagnosis of exclusion, specifically hepatitis C with hepatitis C RNA and hepatitis E with an IgM or antibody. Although there's promising data in the literature, there are currently no routinely available biomarkers for drug-induced liver injury. Liver biopsy is not necessary to make the diagnosis, but it may be helpful in certain situations, such as differentiating between DILI and autoimmune hepatitis. The RECAM score provides a user-friendly electronic framework to guide history taking and diagnostic testing, but it cannot replace your clinical judgment. And then conducting appropriate monitoring, such as periodic liver tests when administering new long-term high-risk drugs, should be performed and updated on information regarding the drug side effects. Thank you.